Hello and welcome to the Immunisation Coalition's 2019 Pneumococcal Webinar. My name's Susie Blackburn from the Immunisation Coalition, and tonight we have Angela Newbound, member of the IC and involved in the immunisation program for nearly 2 decades. Thanks so much, Angela.
Thank you very much, Susie, for that introduction. It makes me sound really old, isn't it? 2 decades. We usually talk, 19 years. It doesn't seem, 2 decades sounds much longer than 19 years. But anyway, welcome everybody, and thanks for the introduction, Susie.
Welcome.
That I will set for people tonight really is just hopefully that you'll go away tonight with just one new piece of knowledge. Pneumococcal disease is a really difficult disease, and I think for those of you that have ever read the pneumococcal chapter in the handbook, it's probably one of the most complex chapters of the immunisation handbook. We find that with pneumococcal vaccines, patients are most likely under-vaccinated. Providers seem a little bit frightened of this vaccine. They're scared to give a dose too many. They're dealing often with elderly people with unknown histories from those patients, and so therefore they're a bit scared to give it. But we really must say it is better to give the vaccine than not give the vaccine, because we really cannot over-vaccinate somebody. We are more at risk of under-vaccinating. So what we'll do first is we'll step into our first poll question, just to kick off the...
Okay, the poll question's been launched.
Lovely. So what is the most common bacterial agent for community-acquired pneumonia? So you should be able to tick a radio button.
Yep, there's lots of answers coming through.
Beautiful.
Can you see those results, Angela?
No, I cannot.
All right. Okay, so still going, but at the moment we have about 60% on A, Streptococcus pneumoniae.
Beautiful.
The second answer is about 10 people have answered Staphylococcus pneumoniae.
Yeah. Okie dokie.
And about 10% on each of the other 2 answers.
Perfect.
And 73% have voted.
Okay. All right, how are we going, Susie?
Okay, so it looks like we've got about 63% on A being the answer.
Okay.
20% are on Staphylococcus pneumoniae.
Yep.
And about 10% on the others.
Okie dokie. All right. Well, let's go to our first slide, because we'll be able to give you the answer.
I'll end that poll.
You'll end that one?
Yep. I can share the results.
Beautiful. Ah, look at that. Yes, I can see the results now. Perfect. Okay. So the bacteria really that is responsible is Streptococcus pneumoniae, so which was A in the poll. So anybody that answered A has got it correct. So pneumococcal disease is responsible for more deaths worldwide than any other pathogen, which I think is really amazing, because we get so focused on flu or rotavirus or measles, etc. But, this is a really significant disease all around the world. This particular bacteria, has this polysaccharide coating, which therefore, so polysaccharide meaning many in poly, and sugars being the saccharides. And the composition of those polysaccharides on the outer surface of the bacteria are very similar to the polysaccharides that we have on some of the cells that we have in our body. So when we actually get infected with this particular bacteria, our immune system isn't sure how to respond to it. So it doesn't know whether to mount an immune system response and build antibodies because it's not really sure whether it's a threat or not. We actually can carry this bacteria. We're a natural reservoir for it on the mucosal surfaces of our upper respiratory tract. And we don't have any symptoms of that. But vulnerable individuals who can't manage that bacteria to be harmless and to sit there certainly can end up with, really high risk or certainly increased risk of invasive pneumococcal disease. From the time somebody becomes infected and develops the symptoms is around about 3 to 4 days on average. That can vary a little bit, let's say 1 to 10, but around about 3 to 4 days. And these individuals will remain infectious until they've had some antibiotics. And so around about, 24 to 48 hours worth of antibiotics. And they'll be fine. Certainly won't be infectious, put it that way. Oops. Moving on. Susie, I'm not moving on.
Not moving on, having trouble moving forward.
Yeah, and I've lost my little, there it is. So, okay, so I can't even move forward that way. I don't know why I can't move forward, Susie.
I'm just wondering if I should share. You refresh your PowerPoint screen, maybe, Angela.
I'm frozen, really. I can't get in or out or anything. Sorry about this, everyone.
Maybe we unshare, and if you wouldn't mind opening it again, we'll see if we have more.
Yeah.
Yep.
Stop sharing. All right, let's have a look again. And let's go to here again. And let's go to that slide there. And we shall open that up. Oh, no, that's not going to do that. Oh, there we go. We've moved on. Let's see how we go.
The fun of technology.
It's a gripping thing. Okay. So in regards to pneumococcal disease, we see that pneumococcal disease can be either invasive or non-invasive. So our non-invasive type diseases obviously are things like our sinusitis and otitis media, septic arthritis, osteomyelitis, etc. But what differentiates invasive pneumococcal disease, and you'll often see that abbreviated as IPD. So if we've got a diagnosis of IPD, it actually means that this particular bacteria, Streptococcus pneumoniae, is detected in normal sterile sites, such as the blood and things like the spinal fluid. But we'll talk about that fairly shortly. But otitis media is probably the most common non-invasive type of pneumococcal disease, with around up to about 55% of middle ear aspirates from children with acute otitis media will actually be Streptococcus pneumoniae. So it's a complex disease. We talked about that before we sort of started the presentation realistically. So airborne droplets, we've got nasopharyngeal carriage, We then can develop different pathways, so it's either going to be that non-invasive disease or it's going to be invasive disease. So it's a disease that we need to be aware of when people are presenting with a variety of different symptoms, because it can progress to be invasive quite quickly. So we talked before in regards to treatment with antibiotics, and penicillin really is the treatment of choice. But obviously people who are allergic to penicillin, we're not going to endanger their life and induce an anaphylactic reaction. So, these individuals may be given cephalosporins, really. Dosage and administration really depends on the clinical acuity and the site of the infection. But, definitely take some blood, definitely take a cerebrospinal fluid specimen if you possibly can before commencing the therapy. So it really depends on the prevalence of, antibiotic resistance is becoming a bit of a problem, but that really does differ by state and territory and certainly by country. But that's a concern if we are now developing this type of bacteria is becoming resistant to antibiotics. It's going to be quite a problem. So we talked before what is invasive pneumococcal disease, and like I said, it really is being able to isolate S. pneumoniae from normal sterile sites, blood, joint fluid, cerebrospinal fluid. If you look at the slide there, major clinical presentation, most commonly in adults is going to be a pneumococcal pneumonia. But in children, it's going to be likely to be bacteremia without focus. IPD can certainly manifest as a meningitis, and certainly before we were vaccinating children against pneumococcal disease, it certainly was one of the leading causes of meningitis and deafness in children, bearing in mind that otitis media is the most common presentation in children. So it can be life-threatening. People certainly can lose digits and limbs to this disease. So amputations may need to occur, very similar to that of a meningococcal infection. But hopefully people can seek treatment and get the appropriate antibiotics as quickly as they can. In regards to burden of disease in Australia, these are sort of the latest figures that we could get, and this is from about 10 days ago now. So if we look at 2018 data, just over 2,000 cases were reported to the National Notifiable Diseases Surveillance System. A lot of those cases were obviously in children under 5 and in individuals over 65 years of age, and that tends to be a typical trend for pneumococcal disease. It is a disease of younger children and the elderly in the majority of instances. We will talk about people with medical risk factors down the track, so individuals that are between 5 years of age and 65. If they have medical risk factors, then certainly that will increase their risks of invasive pneumococcal disease. But generally this young children particularly, and the elderly are at most risk. Up until the 31st of March this year, 279 cases reported, which is a little bit of an increase in regards to what was reported in the first quarter of last year. So this surveillance, anybody can look at this data, just find it on the website. We've got a website there, so the government do publish this data. Interesting when we look at the different pneumococcal serotypes that are causing IPD, and we look at those particular 3 serotypes, so serotype 3, 19F and 9N. Serotypes 3 and 19 are actually covered by Prevnar 13 and Pneumovax 23, whereas serotype 9N is covered in Pneumovax 23. So some of the disease is certainly caused by vaccine preventable serotypes. We have a reasonably stable spread of disease across the country, except Northern Territory tends to take the lead. Pneumococcal disease generally is noticed and has certainly been a trend in Aboriginal populations. And prior to the vaccine era, pneumococcal disease was about 75 times higher incidence in the Aboriginal communities than the non-Aboriginal communities. And that's why when this vaccine program first started, they were quite targeted vaccine programs, and particularly for the Aboriginal people. So Northern Territory does have a high Aboriginal population, which may well account for the fact that their numbers are so high. But the spread across the country otherwise is, relatively even. If we look at the trend of notifications over a period of years, there's certainly peaks and troughs, but it certainly looks like we're not making great headway. You know, when we look at vaccine preventable disease, we would really like to see, the left-hand side of the graph, high being the non-vaccine era, vaccine gets introduced, and the right-hand side of the graph, we're seeing very, very little disease. But we're really not seeing that success with pneumococcal disease. And that's because there's around about 90 different serotypes of pneumococcus. So the vaccines don't cover all of those serotypes. And we'll look at serotypes and what's causing disease very shortly, and you'll have a better understanding of why this graph is not looking as though we're winning the war on pneumococcal disease. So this graph is the classic example. So we're looking at non-Indigenous Australians over 65 years of age, and this is for the data up until the 31st of March. And you can really see by the coloured bars what's happening in regards to what are the serotypes that are being notified as causing invasive pneumococcal disease. And you can see that, some of the serotypes in that real light blue, which is the 13 valent or your Prevnar 13, yeah, there's a little bit of that still happening. The green bars are the 23 valent serotypes, but then you look at those red bars and they seem to be almost outnumbering every section, or certainly a lot of those sections. So there's also serotypes that aren't specified in these notifications, but non-vaccine serotypes that are causing disease are problematic because they make our numbers look as though we're not winning the war. If we're looking at, these particular serotypes across all age groups, so that last graph, remember, was the over 65-year-olds. But if we're looking at all age groups now, we kind of get a slightly different picture. But once again, that pale blue bar, we're looking at the 13 valent serotypes, so the Prevnar 13 serotypes that are causing disease, as well as the 23 valent, which is the green bars. But once again, those non-vaccine serotypes are still playing a role in the number of notifications that are coming forward each year. Sorry about the quality of this particular graph. It was sort of a difficult one to cut and paste, but hopefully you can get the concept. So this is children less than 5 years of age. So these are the children that should have received 13-valent pneumococcal vaccine, or Prevnar 13. Certainly you can see when 13-valent replaced the old 7-valent Prevnar on the National Immunisation Program. And that replacement of the 7-valent with the 13-valent certainly made quite a significant difference in the serotypes that are causing disease in young children. So once again, we're looking at those non-conjugate vaccine serotypes. So that is going to be the serotypes that this vaccine does not cover against. They may be serotypes that are covered by Pneumovax 23, or they may be serotypes that are not covered by either vaccine, and thus certainly still playing a major role. But we certainly have made headway in the number of serotypes, certainly in that 13-valent vaccine that is covered by the Prevnar 13 vaccine. Got to remember also that immunising children against pneumococcal disease is actually got a little bit of a flow-on effect, and there has certainly been, over a period of time, a decline in invasive pneumococcal disease in the elderly. So important to get these children vaccinated. So we talked about that decline, and that was a really big decline. You know, you can see that on that particular graph, but it seems to have stabilised, doesn't it? You know, you look back at that graph and it doesn't seem that we're making really much more difference now. So that decline is no longer evident. So it's about really managing it. And you think back to July last year, there was a change in the Prevnar 13 program for children. So prior to the 1st of July last year, children were receiving Prevnar 13 as a routine vaccine at, 2 months or 6 weeks, 4 months, and 6 months. But we were seeing breakthrough disease in these young, fully vaccinated children. So the decision was made based on overseas data and, certainly the experts that we have in this country to change the schedule and give it the first vaccine at 6 to 8 weeks, second vaccine at 4 months of age, and then the third vaccine at 12 months of age. So therefore, protection was afforded to these children for that second year of their life. So we talked about the fact that young children, so particularly less than 2-year-olds and the elderly, Aboriginal Torres Strait Islanders are certainly at risk of IPD, as are those people with medical conditions. And if you look in the immunisation handbook, it will talk about what we see is category A medical conditions, which are the medical conditions that are associated with the highest increased risk of invasive pneumococcal disease in this individual. So there is a whole range of medical conditions that are listed there. If any of your patients have any of those medical conditions, then they really should be receiving some additional vaccine. So this brings us to our second poll, just to see how you go with answering the second question.
Just trying to access poll number 2 and ready to launch. There we go.
Great. So which of these category A medical conditions has a different pneumococcal vaccination schedule?
%20 have voted.
Lovely.
It's a real range across the 4 answers. We've got
Wow, okie dokie. Yeah, good.
50%. Still going. 65% have voted.
Excellent.
Give them a little bit longer.
Perfect.
70%. We'll keep going. Okay, responses have slowed now. So what I might do is share. Would you like me to share that now?
Absolutely, thank you.
Okay, and share results. There we go.
All right. Very, very interesting. All right. Well, the true answer to that question is actually hematopoietic stem cell transplant. So if you have a patient with a category A medical condition, they are going to be recommended to have 1 dose of Prevnar 13, followed by at least 3 doses or potentially 3 doses of Pneumovax 23 in their adult lifetime. However, hematopoietic stem cell transplant recipients are actually recommended to receive 3 doses of Prevnar 13. Okay, and then some Pneumovax 23 doses thereon. So the number of doses will really depend on when the diagnosis was made or when the treatment was made. How old was the individual at that time? So good job.
Okay, we'll stop sharing that one. Thank you.
Good. Oops. Okay. So with our category B medical conditions, so this is the conditions that are associated really with an increased risk of invasive pneumococcal disease. And these are your severe asthma patients, diabetics, with liver disease, your little preterm infants. So if you have a preterm infant, they are considered medically at risk. Therefore, with your pneumococcal schedule, your Prevnar 13 then would be given at 6 weeks or 2 months, another dose at 4 months, another dose at 6 months, and then their dose at 12 months. So little children that qualify with any of these medical conditions, either category A or category B, would receive an additional dose of Prevnar 13 at 6 months of age. Okay. And while tobacco smoking, really isn't a medical condition like it says there, people who smoke really do have an increased risk of pneumococcal disease, and we would certainly be suggesting providers have conversations with patients around having some protection against pneumococcal disease. So let's have a little look at those people who do have risk factors, those underlying medical conditions.
Just before we move on, Angela, we've just got a question for
sure.
13. Just the amount again for the stem cell transplant in terms of the timing. And
yeah.
Yes, please.
Okay. So if you have a hematopoietic stem cell transplant, all right, the recommendation would be, and there is a table in the handbook that will sort of spell what vaccines you need to actually give. Okay, so it will actually talk about 3 doses of Prevnar 13. Okay, and those 3 doses, according to this table in the handbook, are going to be given at intervals. The first dose is at 6 months post-transplant. The next one at 8 months post-transplant. And the next one is at 12 months after the transplant.
Great, thank you.
Okay.
Thank you.
Okay, so we know that adults that have got chronic medical, and we're going to start talking about adults now, chronic medical conditions certainly have a significant increased risk of invasive pneumococcal disease compared to adults that do not have a medical condition. Pneumococcal disease and diabetes it's quite a serious disease for these individuals. You know, we do know that people with diabetes have a deficiency in order to protect themselves from disease. They are certainly more likely to A, contract disease, and B, have serious complications from that disease. We definitely know that diabetes is a risk factor for cardiovascular and renal disease, and we certainly know that any of these diseases that cause fever will certainly cause inflammation of the vessels, and we know people with diabetes, because of poor glycemic control, their vessel walls lose their elasticity. They're quite likely to have plaque on their vessel walls, and we know that once these vessel walls become inflamed, there is certainly a risk that plaque could fall off the walls of these vessels and increase risks of things like heart attacks and strokes. So we really need to be mindful of offering this vaccine to anybody with any of these risk factors. So look at the handbook and make sure, please, that you're using that online version of the handbook. I'm still finding a few providers that are hanging on to that lovely orange book. But that little orange book really does belong in the rubbish bin now. It is so out of date, and we would hate for providers to be being guided on recommendations that have now been superseded. So people with chronic heart failure certainly, once again, are at risk of infection. They certainly don't cope well when they do become ill with these infections. And respiratory infections, of course, are certainly a cause of that acute cardiac decompensation in heart failure patients. So this disease is, like we said, a disease of very young children, but certainly it's a disease of the elderly. And it's a very difficult disease probably to vaccinate against in the elderly because of that poor patient recall. They may have moved providers several times. They don't remember where they had their last vaccine. They don't remember what vaccines they've had. And therefore, providers are wondering, well, do we take the risk of giving them an extra vaccine or not? And, you know, a lot of providers are comfortable not to take that risk of giving an extra vaccine. But it's probably really important that providers rethink that choice, because we can't really technically over-vaccinate, but at least if we've vaccinated that individual, we've got a record of a dose being given. So there's some more guidelines. So patients with COPD, once again, this is a disease really that's going to affect our pulmonary system. We talked about pneumococcal pneumonia being the most common presentation for adults. So it certainly is going to exacerbate people that do have any type of chronic obstructive pulmonary disease, people that are, that are asthmatic, and certainly, people that are on these high-dose inhaled corticosteroids really have that impaired airway and therefore become quite susceptible to this particular infection.
Just on that, Angela,
yeah.
I've got a question here about immunosuppressive therapy and prednisolone.
Yes.
The question is saying, if someone is on 5 milligrams prednisolone daily for several months or years, would they be considered category A?
So I'm going to just take a minute and see what that guideline is. There is a certain dose that will determine whether or not somebody is considered to be immunosuppressed. So I will find that information in regards to that question, and I will get back to that if I can't find it straight away.
No worries, thank you.
Have a real little quick look here. I'm just going to go to recommendations for category A's. Okay, so immunosuppressive therapy, including corticosteroid therapy, is greater than or equal to 2 milligrams per kilogram per day.
Oh, wow.
Prednisolone or equivalent for more than 1 week.
Okay, so someone on a lower dose of 5 milligrams daily for months or years.
Yeah, so they would be considered to be having an immune compromising condition if they're on a dose that's that large. So is it 5 milligrams per kilo per day that they're on? Next question.
Sorry, did you get that? It hasn't been specified in this.
Okay. Yeah, so it's greater than or equal to 2 milligrams per kilogram.
He's just got back to us and said just 5 milligrams.
Right, so just a 5 milligram tablet a day would not put them into that immune suppressive state.
Okay, thank you very much.
Okay.
Thank you.
Perfect.
There are more questions coming up, but we'll let you continue if you like, and we'll bring them up before the next poll. For sure.
Okay. So the question around severe asthma, what is severe asthma? We could ask 20 people about what is severe asthma and people would have 20 different answers. But look, realistically, people that are classified as severe asthma usually means that they're on multiple medications and they have at least a hospitalisation a year and probably multiple hospitalisations a year. So we do know that, asthma is a risk factor for IPD. They are at risk. So once again, if you've got patients with any of these chronic medical conditions and they're presenting to you unwell, they may have, pleuritic pain, they might be struggling a little bit, certainly draw some blood, let's test them, get a sputum specimen, whatever it is that you need to do, and test to see whether or not you're dealing with a pneumococcal infection and get them on the appropriate antibiotics. So here's our cigarette smoking individual. And as all healthcare workers, we don't like our patients smoking. patients that smoke are at such increased risk of almost every disease that's walking around the place. They're at increased risk of flu, they're increased risk of pertussis, they're increased risk of pneumococcal disease. But it's a bit scary to say that, it is the strongest independent risk factor among immunocompetent, non-elderly. So you're taking out those risk categories, taking away the fact that they're old, take away the fact, that they have a medical condition. So they don't have a medical condition and they're not old, and yet that is the strongest independent risk factor. So if you've got individuals that come to your practice that are smokers, now's the time really to talk to them about giving up the cigarettes and helping them get onto a quit smoking plan. About half of otherwise healthy individuals with IPD are tobacco smokers. So really, really significant. So we're going to lead into another poll. Thanks, Susie.
Okay. I'm just wondering if it's a couple of very quick answers.
Sure.
Questions, if that's okay.
Yeah.
For diabetic patients, are vaccines funded?
Okay. Good question on that one, because we're actually going to be talking a little bit later in the presentation about a tool that's available for you to use. It's an online tool that's going to tell you what vaccine to give to your patients, and is it funded under the NIP, is it funded by PBS, or is it unfunded and at the patient's expense. So we'll talk about that really, really shortly.
Great. And the only other one we could do now, please, is people with category B diseases less than 65 and not on the schedule have to pay. Do you think that's a possible barrier to vaccination?
Yeah, okay. Look, we certainly do know. What we do know is that individuals that have medical risk factors are able to have 2 doses funded by NIP. The other dose is funded under the PBS. So it's not an expensive thing. Now, the expense really is more so with a category A patient, because they need Prevnar 13, which is not PBS listed and not funded under the NIP. Now, this is really concerning in the fact that these category A individuals have a condition that places them at the highest risk of invasive pneumococcal disease, and we're recommending a vaccine to them that they've got to pay for completely, fully, no PBS, no NIP. So if you want to make some noise about that, then go and knock on the politicians' doors, do what you need to do, because certainly people that need to pay for vaccines, it is a barrier. And if you've got somebody with a medical condition such as a category A, they have probably well and truly been very sick. They're probably on a disability pension. They probably haven't been working for ages. They've run out of sick leave, etc., etc. So, my personal opinion is that, yeah, it's very unfair that we make these patients pay for these particular vaccines. And I think it's some work that needs to be done along the way. So, if you want to get out there and advocate for this and change happening for these individuals, then, I'd certainly encourage you to do that.
Thanks, Angela. Are you ready to launch
Sure.
number 3?
Absolutely. So, is it a requirement to exclude a person with pneumococcal disease from work or school?
%?
Lovely.
70% have voted.
Ooh, very good.
Okay, we've slowed down at about 80%.
Well done.
And I will give them 5 seconds. Oh, a couple more.
Good.
And end poll.
Lovely.
Sharing the results.
Ooh, very interesting. The answer is actually C. No, they do not need to be excluded from work or school. If they feel well enough to go to work or go to school, they certainly can. They can just continue to take their antibiotics, not a problem at all. Okay, so there's no exclusion requirement at all.
Thanks for that.
Good work.
Great, thank you.
Okay, so if we look at the background of pneumococcal vaccines, there were individual programs that were happening, you know, for high risk individuals, you know, really way back 1986. But the universal program, so every child having pneumococcal disease for and adults as well, started in 2005. And you'll see that there's been a shift and a change of who gets which vaccine and what time and you know, how many doses. We used to start with, you know, adults with 23 valent, it was a dose every 5 years, and then it came 2 doses 5 years apart. Well, now for a healthy individual over 65 years of age, it's just a single dose. Aboriginal population, we need to offer a bit more protection to. So once an Aboriginal person without a medical risk factor gets to 50 years of age, they get 2 doses 5 years apart, so one at 50, one at 55. But certainly for individuals with medical risk factors, definitely they can be accessing this vaccine a little bit earlier, either as a NIP or as a PBS listed vaccine. So it's an interesting time frame. Where this will go, we're not really sure. This has been discussed at really, really high level about, you know, is there a place for both of these vaccines, or should we be giving 13 valent vaccine to everybody? Should we be giving a dose of 13 valent followed by a dose of 23 valent? And the jury is out on that, you know, there's just not enough data to really support what we should be doing with this. And, you know, it really is something that the experts around the world are actually debating on what to do with these particular vaccines. So we've got one more poll. We might as well get that out of the way straight away, shall we?
Oh, here she comes. And launched.
Ah, there we go. So we've got 2 vaccines. What is the difference between Prevnar 13 and Pneumovax 23?
%50 voted.
Ooh, very good.
We're up to 70%, slowing, so I'll give 5 or 10 more seconds. Filtering in, a couple of seconds. 75% of votes are in, and ending the poll. Here's the results.
Ah, very, very good. Well done. Yes, B is the answer. One is a conjugate vaccine and one is a polysaccharide vaccine. Question C was a little bit of a trick question, that they provide protection against completely different serotypes because they actually share protection against a number of those serotypes. Okay, so let's go to this particular slide. So you can see that 6A serotype is unique only to Prevnar 13. The serotypes with the stripy bars are serotypes in both Prevnar 13 and Pneumovax 23. And the solid purple bars are serotypes that are unique just to 23-valent vaccine. So this is a really great table, you know, download this and, you know, stick it up on the wall. Fantastic. So 23-valent means that it provides protection against 23 of those 90-odd serotypes of pneumococcus. So being a polysaccharide vaccine, where our immune system doesn't recognise it very well, they are not suitable vaccines for children less than 2. So that those really immature immune systems are not going to know what to do with this particular vaccine. They're not going to know whether to mount a response or not. So what would happen is we give this vaccine, antigen presenting cell comes along, kind of doesn't know whether to recognise it as a threat, but thinks it should do something. So it sort of does a little bit of something, but then it doesn't really spit proteins out onto its surface. And therefore the T helper cell doesn't understand that it needs to come and support the antigen presenting cell. So it ends up that this is a T helper cell independent vaccine, and therefore it's not going to elicit an immune response very well in a young child. So vaccine's been around certainly for a while, like we saw. Can be given either subcutaneously or intramuscular. Certainly intramuscular is the preferred route. We see a greater rate of injection site reactions with subcutaneous administration. But look, if you give it subcut, you don't need to repeat the dose. But if you've got the option to give it intramuscularly, then that would certainly be preferred. It is a bit of a problem vaccine in the fact that of this, you know, hypo-responsiveness. And what does that really mean? Well, you know, it kind of is a blunting of antibody response, but you know, after repeated doses, but nobody really knows at this stage whether that's significant or not. You know, is there a significant negative outcome on the actual vaccine effectiveness? And nobody really knows. But for that particular reason, that hypo-responsiveness or that blunting, you know, they really did look at what are the benefits of giving more than one dose and therefore scaled back the number of doses. So, you know, we can got a vaccine, it's the best that we've got, still absolutely worth giving regardless, but we probably wouldn't continually give this vaccine more than the prescribed 3 doses in an adult's lifetime if they have medical risk factors. So 23-valent is on the NIP funded for people over 65, Aboriginal Torres Strait Island people 15 years and 50 years and over, and also Aboriginal Torres Strait Islanders that have medical conditions if they're aged 15 to 49 years of age. And certainly for those little children that we talked about before, we were giving them that extra Prevnar dose at 6 months. We're going to bring those little ones back in at 4 years of age and give them a dose of Pneumovax 23. On the PBS, like I said, for other people that are at risk of pneumococcal infections. So 13-valent is a conjugated vaccine. So what they've done is they've taken that polysaccharide coating, but they've chemically linked it to a carrier protein. So this is a non-toxic diphtheria protein that's used. We're not protecting the child against diphtheria with this vaccine, but it's just a protein that's been used. Our immune system responds to the protein, to the carrier protein, rather than the polysaccharide. So it's the carrier protein that elicits the antigen presenting cell to spit out some bits of protein onto its surface, and therefore is asking the T helper cell to come and help. So now we've gone from a T helper cell independent vaccine to now being a T helper cell dependent vaccine. So then we're going to get nice chemical cytokine release, stimulation of those naive B cells to go and produce antibodies. So we need to protect these little ones because they're in that highest risk factor of pneumococcal disease. Dosage in adults, we talked about the childhood schedule a little bit earlier, but a single dose is recommended for any adult that has a category A medical condition. Even if they've had a dose of 23 valent already, they still should have a dose of Prevnar 13 if they've got a category A. At this stage, we don't know whether we need to give any boosters, okay? Certainly for, the best efficacy and protection, if you're going to be giving a dose of 13 valent as well as followed up by 23 valent, definitely give the 13 valent first. And then a couple of months later, you'd be giving your first dose of your Pneumovax 23. If you happen to give a dose of 23 valent first, then it's recommended that you wait 12 months to give that dose of Prevnar 13. It's a pretty reactogenic vaccine. We tend to say give it in a limb by itself. That's a little bit hard for our providers here in South Australia with the children program because we're giving Bexsero, and SA Health have asked for Bexsero to be given in a limb, the left limb exclusively, which just means our little ones are getting their Infinrix Hexa and their Prevnar 13 in the same right limb at 6 weeks and at 4 months of age. But otherwise, it's a reactogenic vaccine. We'd give it normally in a separate limb. So this is that childhood schedule that we've already gone through. We used to have it at 2, 4, 6 months. It's now gone to 2, 4 and 12 months as the routine schedule. We talked before about that additional dose. So Aboriginal children living in Queensland, South Australia, Northern Territory and Western Australia, these 3 states and the Territory do have a funded Aboriginal children's program. It is an NIP funded vaccine, but it's not an NIP program because it doesn't occur in every state and territory. So please ask the question, do you identify your child as Aboriginal or Torres Strait Islander if you live in these states or in the Northern Territory? And ask that question every time because they are eligible to receive an additional dose of Prevnar 13 at 6 months of age, same as those medically at-risk children. This is a little bit of just a quick chart that will just go through how many doses should they actually be receiving and the category A and category B medical conditions, whether you're Indigenous or not Indigenous. Coverage, we do really, really well with children and we measure that. They're all funded vaccines for children, but trying to find data on adult uptake is really quite difficult. Coverage reports are not produced like they are for childhood reports. So, we now have the AIR, we've got the ability to capture pneumococcal vaccination data or any vaccination data for adults. But of course, we've only had that in place for a few years. So we've got to wait and see what that data is going to look like over time, given that this is not a vaccine that gets given every year, etc. But certainly based on previous studies and sector estimates, uptake appears to be quite low in adults, particularly those that have got medical risk factors. So I would really urge you to look at the Pneumosmart vaccination tool. It's hosted on the Immunisation Coalition website. It's a very, very easy tool to use. I would perhaps like to challenge you that when you go back to your organisations or your practices, have a look at the Pneumosmart tool. Do a little search through your practice management software, select out some patients, maybe 10 patients that have got either category A or category B medical conditions, run them through the tool and find out, have they been vaccinated appropriately? And if not, put on a recall and get them back in. So you do need to agree to the terms and conditions. This is a tool to assist providers, but we do recommend providers do follow the guidelines also in the immunisation handbook. But it is a very, very easy tool to use. The very front page of the tool is going to ask you for the person's name and date of birth. That information is really just so when you print out the document, if that's what you're going to do at the end, you know which patient you've just run through the tool. That data is not collected otherwise, but other data is collected into the background. So please use the tool. It's there for you because this is a pretty complex disease and vaccine program. So it doesn't worry about catch-ups for kids because you've got the catch-up calculator, immunisation calculator that's going to help you do that for young children. So this is really for people that are going to be, that are over 5 years of age. But just always remember, we build on doses that are documented. So if somebody had a documented dose of vaccine 5 or 10 years ago, we are just building on what we already know that they've had. But if they cannot produce a record, there is no records found anywhere, then we proceed as though they have not ever received pneumococcal vaccination. So we're right on time. Are there any questions, Susie, that I just need to answer quickly before we conclude?
No, all questions have been answered either by yourself live or typed by myself. So we are on target to finish if you haven't got
That is great. Thank you, Susie. So just to conclude, we know that pneumococcal disease can cause considerable morbidity and mortality. The very young children, the elderly, Aboriginal and Torres Strait Islanders and people with chronic medical conditions are at increased risk. There are guidelines in the handbook. Certainly use the Pneumosmart vaccination tool as well. Just make sure that those children that are eligible for that dose of Prevnar 13 at 6 months are actually getting it, but children without medical conditions are getting their 3rd dose at 12 months of age. And just making sure that you are checking all of your patients if they have chronic medical conditions, so whether they've had the right vaccine schedule. So I'd like to thank Susie for being on the other end here today and tonight and helping out. And I'd really like to thank you all for joining the webinar. I hope you are all walking away tonight with just one piece of new information. If that's the case, I have done my job and I am very happy with that. But like I said, my challenge is for you to go back to your practices and grab some patients, run them through the tool, and good luck, and thank you very, very much for listening, and good night.
And thank you to you, Angela. For more
Thank
information,
you.
people can just go straight to immunisationcoalition.org.au, and we will speak to you all next time. Thanks, everybody.
Thank you. Good night.
Good night.